So we've heard how big N data can inform predictive models throughout the day, from the first panel to this one. And as a complementary, not a contrary approach, I also want to introduce the idea of using small data, by which I mean small n equals 1, that patient's data over time, to personalize care, one person at a time, and informed by that one person's data over time. This patient-generated data offer many powerful ways and scalable ways, in other words, affordable ways, to measure an individual patient's status and how they're responding to treatment. The data can serve as a feedback to the clinician about changes in the patient's experiences, symptoms, and side effect. And it's particularly valuable when the clinical encounters are relatively sparse to the course of the condition, so that the value of that high fidelity observability is great. And that's true in chronic conditions like rheumatoid arthritis, or in recovery from some specific intervention like a joint replacement. And these n equals 1 longitudinal data, probably a more accurate term than small, can, in addition to informing how clinicians prescribe and titrate, they can also inform how patients manage and adhere. So patient-generated data come in many forms. Self-reports, such as surveys, patient-reported outcomes, activities of daily living, and they can be assessed much more frequently and with far less user recall bias, because it's much more salient and proximate to the event, particularly when the user interface is built to feel more like social media engagement. So image-based clicks and likes and swipes. Second, there are active tasks, and they make even deeper use of mobile device capabilities. They're not just presenting an image-based question to somebody in the moment about how they're feeling, how they're doing, whether they had pain from walking up those steps. And an active task engages a patient in a quick sensor-measured task, like how long does it take them to walk up some steps, by asking them to walk up those steps and record it, or asking them to do a tapping test, as in a Parkinson's tapping test, but on a smartphone with making use of the sensors and the touchscreen display. Wearables, the third row down there, provide passive monitoring. They don't require that active engagement. They just require somebody to be wearing that wearable. And they monitor biometrics. Things like activity and heart rate are the most common. And so, for example, this Oura ring on my finger does a really good job of using heart rate and activity to compute sleep quality. And it doesn't, it never fails to chastise me when I run too late in the day, which apparently disrupts the quality of my REM sleep. Who would have known? I didn't. It has changed my habits. And also passive data comes just from our smartphones. So our smartphones can continuously capture our location trace, and that is probably the most highly underutilized source of patient status data that we have. Because from that continuous location trace, you can extract mobility patterns, something as simple as how many hours were spent out of the day on a daily basis, and that might signal patient recovery or relapse, and whether that's in the context of depression, or lower back pain, or a GI disorder, or cardiovascular rehab. And finally, there are just digital traces more generally, the last row. These are the least used to date, and these come from our food purchases, more and more online, our Google searches, our social media activity, and some are referring to this as sort of emergent medical data. Over the years, I've found that the most promising way to put these data to use are, first of all, by looking for sources of data that provide more continuous out-of-the-clinic observability of an established physiological or behavioral measurement, rather than pursuing some brand new assessment. Second, to contextualize them with a clear clinical purpose, such as tighter control, rheumatoid arthritis, or an earlier intervention that will reduce some downstream health consequences for the patients and costs for the system. And third, to leverage technology that is already deployed in patients' and in patients' hands and are already part of the clinician's workflow. And the last one is really the biggest challenge now. When I started, and a number of us started doing some of this stuff, more than a dozen years ago, we were still struggling to make the bottom part of this work. Get those devices out there, get the basic activity classification algorithms working. But we have that part working. Now the challenge is sense making. To synthesize that raw data, a lot of what we just heard about, into something that is useful, actionable, and we can think of as a digital biomarker in the way we think of other types of biomarkers that can be integrated into existing clinical workflows so that we relieve and enhance rather than increase clinician work and burden. And these digital biomarkers actually need to be validated for particular conditions, right? That mobility pattern that I mentioned, changes in that mobility pattern, means something very different for a patient managing dementia onset than it does for somebody managing depression. You're looking for different things and different changes. And that same metric, for example, has to be personalized to each individual. If I work at home, my patterns look differently than if I work out of the home, if I'm in school versus not. And that might sound very difficult, but really we can borrow a lot from the algorithms that are already in use that personalize our keyboards and our content recommendations. Most of the work needed to bring patient-generated health data into clinical care and to individualized care is in rapid iterative verification and validation of these new clinical measures. So I presented this small data framing in 2013 in a TED-Med talk, where I reflected on my father's sudden decline at the end of his life, in the last month of his life. And I commented on the fact that the emergency room doctor that I brought him to did not think that there was anything unusual going on because my father presented very well for a typical 90-year-old. Yet I knew this was not typical for him. I reflected that in retrospect, his sudden decline would have been observable in his digital traces. Reduced range and frequency of daily walks, shopping for prepared food instead of groceries, and in erratic responses to emails. And I wondered if maybe that well-meaning but very busy ER doc would have found a digital pulse computed on my father's small data more convincing or interpretable than he found me. I thought the idea was actually a bit here and now for TED-Med in 2013, that it wasn't far enough out there. And even before that, in 2010, when Ida Sim from UCSF and I published this first piece in Science, I thought it was relatively obvious. But it took most of the past decade for mobile devices to really begin to impact care. And that's really excellently described by Ida in her recent New England Journal of Medicine paper, and I highly recommend the podcast. You can listen to it on your way home. So what I reflected on in preparing this talk is that I expected a revolution. I'm a technologist. But we needed time for evolution. And in particular, EHR and mobile phone penetration and interoperability were insufficient to support a change in care 5, let alone 10 years ago. I also underestimated the incompatibility of these sort of common sense, pretty low cost innovations with established healthcare system reimbursement and workflows, and with a sort of VC dominated model for introducing innovative products to market. Well, now we do have the prerequisite technologies in place and in use, smartphones and EHRs, not always in the way that improves patient health or clinical care, but that's material for a different talk. And not coincidentally, we have witnessed a decade of policy-based incentives that catalyze that EHR deployment, and now are ushering in telemedicine and CPT codes for reimbursing remote patient monitoring. Evidence of that readiness is also the availability of the health records that the previous speaker mentioned, in which Apple has really taken a leadership position in making personal health records available through HealthKit. Now, this was also first proposed a decade ago in Blue Button, but now it's happening. This might not seem like such a critical need for patients who are in one of the best health systems in the country, but it is a very important step for many, many Americans who experience care that is less patient-centric and far more fragmented. And it happened because it built on the broad implementation of FHIR-based APIs and the opening up of those APIs to independent patient-centric app developers. And now Common Health is extending those benefits to the users of all Android phones, making mobile health more equitable and more attractive to those app developers. And importantly, both Apple and Common Health communities are actively looking at ways to protect patient privacy and security, because that is one of the threats associated with having all those records downloaded and made available to third parties. Another piece of great news is that we're starting to see patient-reported outcomes actually appearing on the front lines of care. Some colleagues at Memorial Sloan Kettering have initiated a clinical trial to evaluate how providing patients and their caregivers with ongoing real-time support after discharge aids delivery of high-quality postoperative care, end quote. One of their study metrics is avoidable ER visits, which, if reduced, can save costs to the system and also save infection exposure to the patient. Chris Ross mentioned just this issue this morning in his introduction when he said he had this desire for something a little bit more as he left the hospital to help him and scaffold that transition home. I mentioned active tasks concept a little earlier, and when it was first introduced, there were just a few. Now Apple has up on their website a suite of measures that utilize the powerful cameras and microphones and other sensors that are built into our mobile devices and, not coincidentally, our Apple Watches. But these are not necessarily limited to Apple. You can go ahead and develop and validate and share active tasks, and many of them are now implemented across platforms. And I find this method of quick, engaged patient assessments, but that are quantitatively measured, also of particular interest to keep an eye on because of their relevance to other IoT devices. So clearly the touch screens and sensors on our Apple Watches and on our smartwatches, but also conversations with our conversational agents, such as with Alexa, and eventually things like smart mirrors that might be the right place to do a morning check-in. Active tasks are just more objective than self-report and more achievable than what can be privacy sensitive and more difficult idea of trying to extract those things from our continuous use of these same devices. That said, not everything fits into an active task, and Health Rhythms is a great example of using passive data to address behavioral health conditions such as depression. Their Q platform delivers scalable psychosocial interventions, and those interventions are tuned to each patient's state. And they do that, they determine the patient's state by interpreting continuous sensing measurements on the mobile phone. And as we begin to gain experience with these kinds of new tools, I wonder if sharing this deeper sense of the lived experience of the patient through their small data might contribute to greater empathy and trust between patient and her care team. So, Atul appears for the second time at a meeting that he's not attending. I want to close in saying that unlike a decade ago, we have all the pieces in place to apply these techniques broadly across care, which means we can realize Atul Gawande's call to action, and I quote, "To shift our focus from rescue medicine to lifelong incremental care, or leave millions of people to suffer from conditions that increasingly can be predicted and managed. The more capacity we build to monitor the body and the brain for signs of future breakdown and to correct course along the way, the greater the difference healthcare can make in people's lives, as well as in reducing future costs." Thank you.
Thank you very much.